My name is Tom Lynch. I'm the director of the Yale Cancer Center and the physician-in-chief of the Smilow Cancer Hospital. Lung cancer is the leading cause of cancer death in the Western world, in the United States and Western Europe and parts of Asia, including Japan, Korea, Taiwan. It's a major disease that is spreading with increasing frequency because of the use of tobacco products in a number of the countries in the developing world. What's good about lung cancer, and the good news about lung cancer, is that as a society we've been able to reduce our rates of cigarette smoking. And now, in fact, only about 20 to 23% of Americans smoke cigarettes. And because of that, we've begun to finally see some stabilization in the death rate from lung cancer. However, in other parts of the world where smoking is still more prevalent, the number of cancer deaths from lung cancer continue to increase. So for patients who've been diagnosed with lung cancer, it's important that they ask the doctor a couple of important specific questions. First, what is the type of lung cancer that you have? Is it a squamous cell? Is it an adeno? Is it small cell? Is it non-small cell? So type, otherwise known as histology. Second, which genes are abnormal in my lung cancer? Third, what's the stage of my lung cancer? Fourth, what are the options for treatment? And then fifth, are there clinical trials that could be important to help with the care of my cancer? So lung cancer is an area where we've learned so much about the genetics of the disease. Just in the year 2012, 4 important papers have come out which have given us new insight into understanding which genes are abnormal in lung cancer. Now, we knew before 2012, we knew that genes like EGFR and genes like ALK were important targets for lung cancer. In 2012, we learned that there are a whole host of hundreds of other genetic abnormalities that we can begin to look at and think, can we target that? Can we interrupt that pathway to give us a better sense of understanding of the disease? When I look at the new drugs and new avenues in lung cancer, the ones I'm most excited about are treatments which target the immune system and stimulate the immune system to be able to mount an effective response against the cancer. In 2012, we saw the report of the PD-1 papers and the anti-PD-L1 papers. These are incredibly interesting compounds, which are monoclonal antibodies, which actually cause the body's immune system to recognize the cancer and be able to specifically fight the cancer. A real breakthrough. So our testing of patients with lung cancer has also increased dramatically over the past 5 years. We now routinely test lung cancer patients for the presence of EGFR mutations, the presence of RAS mutations, and also whether you may have an ALK or a ROS rearrangement of genes, what's called a translocation. And those are routinely done for most patients who come in with lung cancer. For patients who have other mutations, it's a little bit harder to say that that's become standard at this point. I think it's still something which is developing. At major cancer centers like Yale and Sarah Cannon, we are testing more broadly for larger numbers of potential genetic abnormalities because we hope to find the specific abnormality that could drive a new treatment. So treatment for cancer is challenging for patients and for families. Surgeries can involve a fair amount of time in the hospital and pain and shortness of breath and fatigue and tiredness, and really the fact that a major lung cancer surgery can set you back several weeks in terms of how you're feeling and what your functional abilities are like. And I think people who have surgery for lung cancer certainly need time and effort to be able to recover from that surgery. When one thinks about advanced lung cancer, well, then we're talking about the side effects that you get from chemotherapy or targeted agents. The biggest single side effect is fatigue. You just don't have the energy that you want to have. And it's the kind of fatigue that even when you go to bed and get a great night's sleep, the next morning you wake up still feeling tired. And that's really one of the differences between the exhaustion that all of us feel and the kind of exhaustion that lung cancer patients feel. Other side effects that we worry about decreases in the blood cells that come from chemotherapy, red cells, white cells, platelets. When those are decreased, you're susceptible to anemia, infection, or bleeding. Those become important side effects that we watch for as well. Some of the targeted drugs can cause diarrhea or can cause skin rash. Again, something we're aware of, but something we need to follow very carefully. So again, 2012, 2013 has been a year that's given us much more understanding of the role that screening and early detection can have. For years, I've argued that what lung cancer needed was its version of the mammogram or its version of the colonoscopy. We know that mammograms and colonoscopies save lives because they detect cancer in an earlier state when it can be curable. Lung cancer never had that until the advent of low-dose CT scanning. And what we've learned is that low-dose CAT scanning, when applied to patients who have a history of tobacco smoking, can actually reduce death from lung cancer. Now, one of the big questions is, what age should you start screening for lung cancer? The studies were done with people between 55 and 70 years old who had smoked more than 30 pack years of cigarettes. And a pack year is 1 pack per day for a year, is 1 pack year. So that's 30 years of 1 pack per day smoking. When you look at that population of patients and you look at the people over 55, that's the group that appeared to benefit from screening. Now, a question I'm often asked is, well, what about a heavier smoker who's 50 or a heavier smoker who's 43? We don't know the answer to that question, and we don't know whether looking at younger patient populations might actually be just as effective. It may be.